So our first presentation by Dr. Amy McKenney, second-year resident, on the initial feeding tube in critically ill patients should always be post-pyloric rather than gastric.
All right, thank you, Dr. Freed, and thank you for the video because I had a really hard time making feeding tubes funny. So I have no disclosures. I looked at 3 different meta-analyses and 1 original study, which we'll go over, but first we're looking at what the guidelines say. In Canada, they say that you should essentially put in a post-pyloric tube anytime it's feasible in any unit. The American Society for Parenteral and Enteral Nutrition, or ASPEN, says that basically they're equal unless you have high risk of aspiration or you don't tolerate gastric feeds. And it's really, the recommendations aren't necessarily made on the best data, but we'll look at it. So this is the first study. This is the ASPEN study, so the American Society of basically Enteral Nutrition. And it was published in 2013. They looked at 17 randomized controlled trials comparing efficacy and safety. They were primarily looking at nutrition outcomes, understandably, but they were also considering aspiration, pneumonia, mortality. So their study showed that the majority of the studies did show that they got more nutrition with post-pyloric feeds than gastric. All of the studies did show less gastric residual volume in post-pyloric, which seems to be like an obvious thing. And then 11 out of 11 studies showed no mortality difference between the 2 groups. 10 out of 10 studies showed no significant difference in new onset pneumonia. And there was no difference in aspiration in the studies that they looked at. So while the nutrition part of it was different, the end outcomes really showed no difference. This second study was published in 2018. This is an original study looking specifically at patients 75 years and older intubated in the ICU and comparing their outcomes with the different feeding methods. They were, again, looking for ventilator-associated pneumonias in these. They looked at 141 patients, roughly divided evenly between the 2 groups, and they were matched in both groups. I did include this slide on how they diagnosed ventilator-associated pneumonia because it's a very difficult thing to diagnose. They had 2 different physicians look at the chest x-rays. If there was disagreement, a 3rd physician looked at the chest x-ray, and another pulmonologist looked at the end of the study at all of the pneumonia diagnoses. And this was all done in China. To diagnose pneumonia, they were looking at a new infiltrate, and then hyperthermia, hypothermia, leukocytosis, leukopenia, purulent sputum, different microbial culture results from those on admission, or pneumonia by those same standards 48 hours after extubation. This is a table of the outcomes. Let's see if I can do this here. That's showing up great. This is their primary outcome, ventilator-associated pneumonia. In this study, they did show a significant difference in pneumonias, decreased in the post-pyloric group compared to the gastric group. There was also some differences in vomiting here. Mortality, though, here, there was no difference in mortality or hospital mortality. So again, no significant difference between the groups for duration of mechanical ventilation, mortality, length of ICU, hospital stay, or achievement of energy goal, though they did show more pneumonias occurring in the gastric group. This third meta-analysis is a Cochrane meta-analysis. I believe this one was published in 2019. This one looked at 14 randomized controlled trials, which included over 1,100 participants. And they were really looking at the same outcomes all of the other studies are looking at: pneumonia, mortality, and nutrition goals. This is a plot of all the different studies, all the different dots here, the different studies they included that showed rates of pneumonia between the groups. This is a relative risk of 1 here. So this study showed more pneumonia in post-pyloric. All of these studies showed less, and when they did their analysis, they showed a slightly decreased risk of pneumonia in the post-pyloric group. This is the same kind of a plot, but comparing nutrition, and they showed that there's slightly more nutrition delivered in the post-pyloric group compared to gastric. And then this is one of mortality, and you can see that the relative risk is 1. There's no difference in mortality between the two groups. So overall, they did show a statistically lower incidence of pneumonia in the post-pyloric group, no difference in mortality. They showed more nutrition being delivered in the post-pyloric group, but no difference in ICU length of stay or duration of mechanical ventilation. And they didn't show that the post-pyloric group reached their nutritional target sooner than the gastric group. Lastly, this is the most recent study meta-analysis published, which was actually published earlier this year. This was another one done in China. It was published in the European Journal of Clinical Nutrition. This one looked at 41 different studies, 38 of which were randomized controlled trials, and they were really looking at the same kind of outcomes here. This slide is pretty small. I don't expect you to be able to read it, but this is kind of all the nutritional differences. It's a similar table here showing all the different studies included and whether gastric showed more or post-pyloric showed more. So you can see percentage of nutrition delivered. This study actually showed slightly more with the gastric group. Time required, slightly less in the post-pyloric group, and time to tolerate was less in the post-pyloric group as well. And then this is even smaller, but you can see here, this is length of mechanical ventilation. This study did show post-pyloric feeding had a shorter length of mechanical ventilation and ICU stay. But again, no mortality difference between the two groups, and they included hospital expenses as well, which was no difference between the two groups. So, no difference in mortality, like I said, and they did show a slightly less length of stay and length on mechanical ventilation in this study. So overall, looking at all of the different studies, there are over 70 randomized controlled trials included in all of the meta-analyses. None of the studies reviewed showed any mortality difference between post-pyloric and gastric enteral nutrition. One study and 1 out of 2 meta-analyses that addressed it showed no difference in length of ICU stay or mechanical ventilation. And all but the last, or second to last meta-analysis showed no difference in total nutrition time to achieve the nutritional goal. And notably, in everything that I looked at, every meta-analysis, every study that came up, no one looked at any of this outside of the critical care setting. So there's no data for doing post-pyloric tubes on the floor. And that is it. That's kind of a summary of what we have.
All right. One of the reasons for doing this is this comes up pretty much every day, both I think in the definitely in the ICU, and I think also frequently on the floors for people who need feeding tubes. And there's a big push apparently on the floors to put in post-pyloric tubes in patients, and that usually requires an ICU nurse to come down and put it in because the nurses on the floor aren't trained. And it takes a lot of time and a lot of effort a lot of times to get post-pyloric tubes, and it can take anywhere from 45 minutes to, I've seen nurses struggle for an hour and a half sometimes and fail. So it's a lot of nursing time. And the question is, just how necessary is this? We've kind of adopted a policy more recently for a while we were trying to do post-pyloric tubes in everybody for that reason, because there presumably was a significant difference in pneumonia, although as you can see there's no difference in a lot of the other outcomes. And ventilator-associated pneumonias are notoriously difficult to diagnose anyway, so I'm not sure how accurate these studies are. But taken at face value at least, there's presumably a lower risk of aspiration pneumonia with post-pyloric tubes. But more recently, we've changed our policies, and basically, unless somebody has gastric intolerance or very high risk for aspiration, usually due to gastric intolerance, we just place gastric tubes. If it turns out that they're not tolerating it, then we'll try and get a post-pyloric in at that point. So that's kind of how we've modified what we do in the ICU. And as Dr. McKinney said, there's really no data on non-critically ill patients. So the question that we were going to vote on was the initial feeding tube in critically ill patients should always be post-pyloric rather than gastric. And I don't know if anybody has any comments before we vote on this. Anybody have any comments, questions? Yeah, Dr. Bishop. There is a small difference in some of the meta-analyses, others not, so it's not consistent. The other thing I would point out, which Dr. McKinney didn't note, was that last meta-analysis that had 41 studies, I think, had a lot different outcomes than the first two meta-analyses. If you look at it, they've showed differences in ICU, mechanical ventilation days, and things like that. 21 out of those 40 studies in that meta-analysis were done in China. And I think almost all of the ones, and I think that maybe almost all of those studies were done subsequent to the first two meta-analyses. So I think for whatever reason, the differences are due to the additional studies from China. I don't know the quality of those studies, I don't really know, but it is interesting that the other studies that were kind of worldwide, which included a few in China, didn't really show the same results in the meta-analyses. I don't know if that answers your question, but any other questions, comments? Okay, well, I guess it's time to vote. So how many people feel that this is true? We should be putting post-pyloric in all critically ill patients? How many think that it's plausible that we should be doing that? How many think this is busted, that it's probably not appropriate? Okay. Well, I'll give you the honors. Try and just tap it. No. Hit. Diana. Not going. Double tap. on here, guys?
Oh.
The what? Oh, the laser. That's why. That's right. Thank you.